Good day. I'm Janjimil P. Espejo, a clinical clerk from Cebu Institute of Medicine. Today I'm gonna discuss about chest discomfort. The outline of my discussion will be as follows. I'll start with the introduction, then major causes, and lastly would be the approach of the patient with chest discomfort. Chest discomfort is among the most common reasons for which patients present for medical attention at either an emergency department or an outpatient clinic. The evaluation of non-traumatic chest discomfort is inherently challenging owing to the broad variety of possible causes. The most common diagnoses are gastrointestinal causes, and fewer than 10% are other life-threatening cardiopulmonary conditions. It is helpful to frame the initial diagnostic and triage of the patients with acute chest discomfort around three categories, namely myocardial ischemia, other cardiopulmonary causes, and non-cardiopulmonary causes. This is emphasized because the rapid identification of high-risk conditions is a priority of the initial assessment. Chest discomfort caused by myocardial ischemia, termed angina pectoris, is a primary clinical concern in patients presenting with chest symptoms. Myocardial ischemia is precipitated by an imbalance between myocardial oxygen requirements and myocardial oxygen supply, resulting in insufficient delivery of oxygen to meet the heart's metabolic demands. Myocardial oxygen consumption may be elevated by increases in heart rate, ventricular wall stress, and myocardial contractility, whereas myocardial oxygen supply is determined by coronary blood flow and coronary arterial oxygen content. When myocardial ischemia is sufficiently severe and prolonged in duration as little as 20 minutes, irreversible cellular injury occurs resulting in myocardial infarction. Ischemic episodes are thought to excite local chemosensitive and mechanoreceptive receptors that in turn stimulate the release of adenosine, bradykinin, and other substances that activate the sensory ends of sympathetic and vagal afferent fibers, causing the chest discomfort in myocardial ischemia. Ischemic heart disease is most commonly caused by atheromatous plaque that obstructs one or more of the epicardial coronary arteries. It is considered stable when it results from the gradual atherosclerotic narrowing of these arteries, manifesting as ischemic episodes that are typically precipitated by a superimposed increase in oxygen demand during physical exertion and relief upon resting. Ischemic heart disease becomes unstable most commonly when rupture or erosion of one or more atherosclerotic lesions triggers coronary thrombosis. When acute coronary atherothrombosis occurs, the intracoronary thrombus may be partially obstructive, generally leading to myocardial ischemia in the absence of ST segment elevation. It is classified as unstable angina when it presents as ischemic symptoms at rest with minimal activity or in an accelerating pattern in the absence of detectable myocardial injury, and is considered as non-ST elevation myocardial infarction or NSTEMI when there is evidence of myocardial necrosis as evidenced by elevated cardiac biomarkers. When the coronary thrombus is acutely and completely occlusive, transmural myocardial ischemia usually ensues with ST segment elevation on the ECG and myocardial necrosis leading to a diagnosis of ST elevation myocardial infarction or STEMI. The clinical characteristics of angina pectoris, often referred to simply as angina, are highly similar whether the ischemic discomfort is a manifestation of stable ischemic heart disease, unstable angina, or myocardial infarction. The exceptions are differences in the pattern and duration of symptoms associated with these syndromes. Onset of chest discomfort in myocardial ischemia is usually in the morning. Stable angina usually lasts 2 to 10 minutes. Unstable angina has increasing pattern or occurs at rest, and myocardial infarction lasts more than 30 minutes. Chest discomfort characteristics of myocardial ischemia is typically described as heavy, squeezing, pressure, tight, or burning. It is also usually located retrosternally and sometimes epigastric that may radiate to the neck, jaw, shoulders, or arms. This is because the afferent fibers traverse the nerves that connect to the upper 5 thoracic sympathetic ganglia and upper 5 distal thoracic roots of the spinal cord. From there, the impulses are transmitted to the thalamus. Within the spinal cord, cardiac sympathetic afferent impulses may converge with impulses from somatic thoracic tract structures, and this convergence may be the basis for referred cardiac pain. In addition, cardiac vagal afferent fibers synapse in the nucleus tractus solitarius of the medulla and then descend to the upper cervical spinothalamic tract, and this route may contribute to the anginal pain experienced in the neck and jaw. Stable angina is precipitated by exertion, cold, or stress, while myocardial infarction is unrelieved with rest. Chest discomfort in myocardial ischemia or injury is also associated with risk factors for atherosclerosis. Associated features include S4 gallop or mitral regurgitation murmur during pain, S3 or rales, diaphoresis, dyspnea, nausea, fatigue, faintness, and eructations. Presented in this figure are the associated features that increase or decrease the likelihood of acute myocardial infarction. We can see here that the feature radiation to the right arm or shoulder has the highest likelihood that the chest discomfort is due to acute myocardial infarction, while chest discomfort described as pleuritic has the least likelihood that it is due to acute myocardial infarction. Another category of common causes of chest discomfort are the other cardiopulmonary conditions aside from myocardial ischemia. This includes pericardial diseases. Inflammation of the pericardium due to infectious or non-infectious causes can be responsible for acute or chronic chest discomfort. The visceral surface and most of the parietal surface of the pericardium are insensitive to pain. Therefore, the pain of pericarditis is thought to arise principally from the associated pleural inflammation. Because of this pleural association, the discomfort of pericarditis is usually pleuritic pain. The chest discomfort in pericardial diseases have variable onset or duration and has a sharp or pleuritic quality. It is also located retrosternally toward the cardiac apex and may radiate to the left shoulder, trapezius ridge, neck, and upper abdomen. The chest discomfort in this condition is exacerbated by breathing, coughing, or changes in position and relieved by sitting up or leaning forward. It is also associated with pericardial friction rub upon physical examination. Acute inflammatory and other non-ischemic myocardial diseases can also produce chest discomfort. The symptoms of Takotsubo cardiomyopathy are stress-related and may mimic acute myocardial infarction because of its commonly associated ECG abnormalities, including ST segment elevation and elevated biomarkers or myocardial injury. Observational studies support a predilection for this condition to women aging more than 50 years of age. The symptoms often start abruptly with chest pain and shortness of breath, and this form of cardiomyopathy, in its most recognizable form, is triggered by an emotionally or physically stressful event. In acute myocarditis, the symptoms are highly varied. Chest discomfort may either originate with inflammatory injury of the myocardium or be due to the severe increase in wall stress related to poor ventricular response. Other cardiopulmonary causes include acute aortic syndromes, which encompass a spectrum of aortic diseases related to the disruption of the media of the aortic wall. Aortic dissection involves a tear in the aortic intima, resulting in separation of the media and creation of a separate false lumen. It is a less common cause of chest discomfort, but is important because of the catastrophic natural history of certain subsets of cases when recognized late or left untreated. A penetrating ulcer has been described as ulceration of an aortic atheromatous plaque that extends through the intima and into the aortic media, with a potential to initiate an intramedial dissection or rupture into the adventitia. Intramural hematoma is an aortic wall hematoma with no demonstrable intimal flap, no radiologically apparent intimal tear, and no false lumen. It can occur due to either rupture of the vasa vasorum or, less commonly, a penetrating ulcer. Each of these subtypes of acute aortic syndrome typically presents with chest discomfort that is often severe, sudden in onset, and sometimes described as tearing in quality. Thoracic aortic aneurysms can cause chest pain and other symptoms by compressing adjacent structures. This pain tends to be steady, deep, and occasionally severe in quality. Acute aortic syndromes involving the ascending aorta tend to cause pain in the midline of the anterior chest, whereas descending aortic syndromes most often present with pain in the back. Therefore, dissections that begin in the ascending aorta and extend to the descending aorta tend to cause pain in front of the chest that extends toward the back between the shoulder blades. Aortic dissections are associated with hypertension and connective tissue disorder such as Marfan and Ehlers-Danlos syndrome, and upon physical examination, you can hear murmur of aortic insufficiency and loss of peripheral pulses may be noted. Now let's proceed to pulmonary conditions. Pulmonary and pulmonary vascular conditions that cause chest discomfort usually do so in conjunction with dyspnea and often produce symptoms that have a pleuritic nature. The first condition to be considered is pulmonary embolism. The chest discomfort associated with pulmonary embolism may result from the involvement of the pleural surface of the lung adjacent to a resultant pulmonary infarction, distension of the pulmonary artery, or possibly right ventricular wall stress and/or subendocardial ischemia related to acute pulmonary hypertension. Chest discomfort in pulmonary embolism is sudden in onset and has a pleuritic quality, and if massive, it may manifest as severe or heaviness. Location is usually lateral on the side of the embolism. Patients with pulmonary embolism also have associated risk factors for venous thromboembolism, and associated features include dyspnea, tachycardia, tachypnea, and hemoptysis. Massive or submassive pulmonary embolism may also be associated with syncope, hypotension, and signs of right heart failure. The next pulmonary condition to be considered is pneumothorax, or the presence of air in the pleural space. Primary spontaneous pneumothorax is a rare cause of chest discomfort, and risk factors include male sex, smoking, family history, and Marfan syndrome. Secondary spontaneous pneumothorax may occur in patients with underlying lung conditions such as chronic obstructive pulmonary disease, asthma, or cystic fibrosis. And tension pneumothorax is a medical emergency caused by trapped intrathoracic air that precipitates hemodynamic collapse. The symptoms are usually sudden in onset and pleuritic in quality, located laterally on the side of the pneumothorax. In primary spontaneous pneumothorax, dyspnea may be mild, thus presentation to medical attention is sometimes delayed, while secondary spontaneous pneumothorax usually produces symptoms that are more severe. Associated finding upon physical examination includes decreased breath sounds on the side of the pneumothorax. Another condition is pulmonary hypertension, which can increase the strain on the heart, leading to right ventricular myocardial ischemia, causing chest discomfort. It has variable onset, often exertional, pressure quality, substernal location, and may be very similar to angina. It is also associated with dyspnea and signs of increased venous pressure. Other pulmonary conditions that produce chest pain, including pneumonia and malignancy, do so because of the involvement of the pleura or surrounding structures. It has variable onset and duration, pleuritic knife-like quality, unilateral often localized location, and worsened by inspiration or coughing. It is also associated with dyspnea, cough, fever, rales, and occasional rub. Now let's talk about the non-cardiopulmonary causes of chest discomfort. This category is dominated by gastrointestinal conditions and are the most common cause of non-traumatic chest discomfort. They often produce symptoms that are difficult to discern from more serious causes of chest pain, including myocardial ischemia. Esophageal disorders in particular may simulate angina in the character and location of the pain. These cause chest discomfort due to irritation, muscle and mucosal dysfunction, and disturbed nerve sensation. Esophageal disorders include esophageal reflux, esophageal spasm, and esophageal injury. Esophageal reflux often causes a burning discomfort with a duration ranging from 10 to 60 minutes and is located substernally or epigastric and worsened by postprandial recumbency and relieved by antacids. On the other hand, the pain of esophageal spasm is commonly an intense pressure, tightness, burning, squeezing discomfort that is retrosternal in location and, like angina, may be relieved by nitroglycerin or dihydropyridine calcium channel antagonist. Chest pain can also result from injury to the esophagus such as Mallory-Weiss tear or even an esophageal rupture, Borer-Haave syndrome, caused by severe vomiting. Peptic ulcer disease is also considered since it can also cause chest discomfort due to the pain signals referred to the skin and muscles innervated by the same sensory neurons. The chest discomfort is usually prolonged in onset or duration, 60 to 90 minutes after meals, burning in quality, epigastric and substernal in location, and is relieved with foods and antacids. Gallbladder diseases can also cause chest discomfort by the same mechanism as the one described in peptic ulcer disease. The pain is steady, aching or colicky, and usually lasts for several hours. Although the pain arising from these disorders usually localizes to the right upper quadrant of the abdomen, it is variable and may be felt in the epigastrium and radiate to the back and lower chest. The discomfort is sometimes referred to the scapula or may, in rare cases, be felt in the shoulder, suggesting diaphragmatic irritation. The pain may follow after meals and subside spontaneously without symptoms between attacks. Another subset of causes are the musculoskeletal conditions. Chest discomfort can be produced by any musculoskeletal disorder involving the chest wall or the nerves of the chest wall, neck, or upper limbs. Costochondritis causing tenderness of the costochondral junctions is relatively common. This condition causes chest discomfort due to the inflammation of the costochondral joint. The pain is variable in onset and duration, aching in quality, sternal in location, and reproduced by local pressure. It is also associated with swollen, tender, and warm joints. Cervical disc disease can also cause chest discomfort due to the compression of the nerves or the brachial plexus. It may have variable onset or duration, or may be sudden, an aching quality that may include numbness, and may radiate to the upper chest, arms, and shoulders, and can be exacerbated by neck movement. It is also associated with neck pain, weakness down to the shoulder, arm, and hands. Herpes zoster can also cause chest discomfort due to the migration of the virus to the sensory nerves in a dermatomal pattern. It usually has prolonged onset or duration, sharp burning quality, dermatomal distribution, and is associated with vesicular rash in the area of discomfort. Trauma or strain to the chest can also cause discomfort and is usually constant localized aching that can be reproduced by movement or palpation. The last subset of causes of chest pain is the psychological conditions. This causes chest discomfort due to the stress response. The discomfort is characterized by variable, fleeting, or prolonged onset or duration, variable quality, and variable location that may be retrosternal and can be provoked by situational factors. Associated features include dyspnea with feeling of panic or doom and history of panic attacks or depression. Now let's proceed to the approach to the patient. Given the broad set of potential causes and the heterogeneous risk of serious complications in patients who present with acute non-traumatic chest discomfort, the priorities of the initial clinical encounter include assessment of the patient's clinical stability and the probability that the patient has an underlying cause of the discomfort that may be life-threatening. This will stratify the patients into those with high-risk conditions and those with non-high-risk conditions. High-risk conditions include those who have myocardial ischemia and other cardiopulmonary causes and esophageal rupture. These patients with these conditions may deteriorate rapidly despite initially appearing well. Those also with non-high-risk conditions, which includes the remainder of non-cardiopulmonary conditions, has more favorable prognosis during completion of the diagnostic workup. A series of questions that can be used to structure the clinical evaluation of patients with chest discomfort is shown in this table. First, we ask if the chest discomfort is due to an acute, potentially life-threatening condition warranting urgent evaluation and management, and if not, we ask if the chest discomfort is due to a chronic condition likely to cause serious complication, and if not, if it is due to an acute condition warranting specific treatment, and if not, could it be due to another treatable chronic condition. The evaluation of non-traumatic chest discomfort relies heavily on the clinical history and physical examination to direct subsequent diagnostic testing. The clinician should assess the quality, location including radiation, and pattern including onset and duration of the pain, as well as any provoking or alleviating factors. The presence of any associated symptoms or past medical history may also be useful in establishing a diagnosis. The quality of chest discomfort alone is never sufficient to establish a diagnosis. However, the characteristics of the pain are pivotal in formulating an initial clinical impression and assessing the likelihood of a serious cardiopulmonary process. To review, chest discomfort with a quality of pressure or tightness may suggest ischemic pain. A pleuritic pain may be involved the processes involving the pleura, and tearing ripping pain may indicate acute aortic dissection. Burning pain may indicate acid reflux, and severe squeezing pain may suggest esophageal spasm. For the location, substernal pain may indicate ischemic pain, and the pain that radiates to the neck, jaw, or shoulder or arms may also indicate ischemic discomfort. A highly localized pain is unusual for angina. A retrosternal pain may suggest esophageal disorders, and pain that radiates to the back may be indicative of acute aortic syndrome. A pain that radiating to the trapezius ridge may also indicate pericardial diseases. For the pattern, if the pain builds over minutes and is exacerbated by activity and mitigated by rest, it is suggestive of myocardial ischemia. When the pain reaches its peak intensity immediately, it suggests aortic dissection, pulmonary embolism, or spontaneous pneumothorax. When its onset is at the morning, it may indicate myocardial infarction or acid reflux. For the provoking and elevating factors, if the patient prefers to rest, it may be due to ischemic pain. When the pain changes with movement or position, it may be due to musculoskeletal causes. If the pain worsens in supine position and relieved with forward leaning, it may be due to pericarditis. If the pain is exacerbated by alcohol, food, or reclined position, it may suggest gastroesophageal reflux or other gastrointestinal etiologies. Associated symptoms: if the chest pain is associated with dyspnea, it may be due to cardiopulmonary causes. If it is accompanied by sudden respiratory distress, it is indicative of embolism or pneumothorax. And if it is associated with hemoptysis, embolism is a consideration. If it is associated with syncope, it may suggest pulmonary embolism, aortic dissection, or ischemic arrhythmias. And if it is associated with nausea and vomiting, you may consider GI causes and myocardial infarction. And lastly, for the past medical history, if the patient has atherosclerosis, myocardial infarction is considered. If the patient has venous thromboembolism, pulmonary embolism might be the cause. If the patient has connective tissue diseases, consider acute aortic syndromes or pneumothorax. And if the patient has panic attacks or depression, psychological conditions are considered. In addition to providing an initial assessment of the patient's clinical stability, the physical examination of the patients with chest discomfort can provide direct evidence of specific etiologies of chest pain and can identify potential precipitants of acute cardiopulmonary causes, relevant comorbid conditions, and complications of the presenting syndrome. However, because of the findings on physical examination may be normal in patients with unstable ischemic heart disease, an unremarkable physical examination is not definitely reassuring. The patient's general appearance is helpful in establishing an initial impression of the severity of illness. Patients who are anxious, uncomfortable, pale or cyanotic or diaphoretic may indicate that he or she has acute myocardial infarction or other cardiopulmonary disorders. Patient may also massage or clutch their chest and may describe their pain with a clenched fist held against the sternum, called the Levine sign. If the patient is young, tall, thin, and it is a male, it is indicative that the patient may have Marfan syndrome that increases his probability to have pneumothorax on an acute aortic syndrome. For the vital signs, patients with significant tachycardia and hypotension may indicate hemodynamic consequences of the most severe conditions. Patient with severe hypertension predisposes to acute aortic emergencies, and patient with sinus tachycardia may indicate submassive pulmonary embolism. Patient with tachypnea and hypoxemia suggests a pulmonary cause, and patient with fever may suggest infection, myocardial infarction, or thromboembolism. Examination of the lungs may localize a primary pulmonary cause of chest discomfort. A unilateral absence of lung sounds may indicate pneumothorax, while a pleural friction rub may suggest pleural processes, and rales may suggest pneumonia and severe ischemia. For cardiovascular assessment, an S3 or S4 may suggest conditions with systolic or diastolic dysfunction, and a mitral regurgitation murmurs indicates STEMI, an aortic insufficiency murmur indicates aortic dissection, and a pericardial friction rub indicates pericarditis. An elevated jugular venous pressure indicates pericardial tamponade. Vascular pulse deficits indicates chronic atherosclerosis that predisposes to coronary artery disease. Loss of pulse plus pallor in upper extremities may suggest aortic dissection, and a unilateral lower extremity swelling may suggest venous thromboembolism. For abdominal examination, localizing tenderness indicates gastrointestinal causes, and hepatic congestion suggests chronic diseases. And lastly, for musculoskeletal assessment, pain from costochondral and chondrosternal joints indicates costochondritis, and sensory deficits in the upper extremities indicate cervical disc disease. Certain diagnostic tests are also important in the initial assessment of chest discomfort, one of which is electrocardiography. It is crucial in the evaluation of non-traumatic chest discomfort, and it is pivotal for the identification of patients with ongoing ischemia as the principal reason for their presentation, as well as secondary cardiac complications of other disorders. Professional society guidelines recommend that an ECG be obtained within 10 minutes of presentation, with a primary goal of identifying patients with ST segment elevation, diagnostic of myocardial infarction, who are candidates for immediate interventions to restore flow in the occluded coronary artery. ST segment depression and symmetric T-wave inversions at least 0.2 millivolts in depth are useful for detection of myocardial ischemia in the absence of STEMI and are also indicative of higher risk of death or recurrent ischemia. Serial performance of ECGs every 30 to 60 minutes is recommended in the emergency department evaluation of suspected acute coronary syndrome. Despite the value of the resting ECG, its sensitivity for the ischemia is poor, as low as 20% in some studies. Abnormalities of the ST segment and T-wave may occur in a variety of conditions, including pulmonary embolism, ventricular hypertrophy, acute and chronic pericarditis, myocarditis, electrolyte imbalance, and metabolic disorders. Hyperventilation associated with panic disorder can also lead to nonspecific ST and T-wave abnormalities. Pulmonary embolism is most often associated with sinus tachycardia but can also lead to rightward shift of the ECG axis, manifesting as an S-wave in lead 1 with a Q wave and T wave in lead 3. In patients with ST segment elevation, the presence of diffuse lead involvement not corresponding to specific coronary anatomic distribution and PR segment depression can aid in distinguishing pericarditis from acute myocardial infarction. Another diagnostics is plain radiography of the chest, which is performed routinely when patients present with acute chest discomfort and selectively when individuals who are being evaluated as outpatients have subacute or chronic pain. The chest radiograph is most useful for identifying pulmonary processes such as pneumonia or pneumothorax. Findings are often unremarkable in patients with acute coronary syndrome. Pulmonary edema may be evident with a characteristic prominent cephalization of pulmonary vessels and curly B lines. Widening of the mediastinum in some patients with aortic dissection may also be seen. Hampton's hump or Westermarck sign can also be seen in patients with pulmonary embolism. And pericardial calcifications are observed in chronic pericarditis. Laboratory testing in patients with acute chest pain is focused on the detection of myocardial injury. Such injury can be detected by the presence of circulating proteins released from the damaged myocardial cells. Owing to the time necessary for this release, initial biomarkers of injury may be in the normal range even in patients with STEMI. Because of the superior cardiac tissue specificity compared with CKMB, cardiac troponin is the preferred biomarker for the diagnosis of myocardial infarction and should be measured in all patients with a suspected acute coronary syndrome at presentation and repeated in 3 to 6 hours. Testing after 6 hours is required only when there is uncertainty regarding the onset of pain or when stuttering symptoms have occurred. Other laboratory assessments may include a D-dimer test to aid in the exclusion of pulmonary embolism. Measurement of a B-type natriuretic peptide is useful when considered in conjunction with a clinical history and examination for the diagnosis of heart failure. B-type natriuretic peptides also provide prognostic information among patients with ACS and those with pulmonary embolism. Multiple clinical algorithms have been developed to aid in decision-making during the evaluation and disposition of patients with acute non-traumatic chest pain. Such decision aids estimate either of two closely related but not identical probabilities. One is the probability of the final diagnosis of ACS, and the second is the probability of major cardiac events during short-term follow-up. Such decision aids are used most commonly to identify patients with a low clinical probability of ACS who are candidates either for early provocative testing, for ischemia, or for discharge from the emergency department. Presented in this figure are some recently developed decision aids. Elements common to each of these tools are symptoms typical for ACS, older age, risk factors for or known atherosclerosis, ischemic ECG abnormalities, and elevated cardiac troponin levels. Although because of very low specificity, the overall diagnostic performance of such decision aids is poor, they can still help identify patients with a very low probability of ACS. Nevertheless, no such decision aid is sufficiently sensitive and well validated to use as a sole tool for clinical decision making. Exercise electrocardiography or stress testing is commonly employed for the completion of risk stratification of patients who have undergone an initial evaluation that has not revealed a specific cause of chest discomfort and has identified them as being at low or selectively intermediate risk for ACS. It is safe in patients without high-risk findings after 8 to 12 hours of observation and can assist in refining their prognostic assessment. Ongoing chest pain is a contraindication to stress testing. Patients who are unable to exercise may undergo pharmacological stress testing with either nuclear perfusion imaging or echocardiography. Selected patients with persistent pain and non-diagnostic ECG and biomarker data, resting myocardial perfusion images can be obtained. The absence of any perfusion abnormality substantially reduces the likelihood of coronary artery disease. Management of patients with normal perfusion images can be expedited with earlier discharge and outpatient stress testing if indicated. Those with abnormal perfusion imaging, which cannot discriminate between old or new myocardial defects, usually warrant additional in-hospital evaluation. Other studies include echocardiography, which is done for those with uncertain diagnosis plus ongoing symptoms. It can detect abnormal regional wall motion, which indicates ischemic dysfunction, or mechanical complications of MI, pericardial tamponade. An intimal flap in ascending aorta indicates aortic dissection. CT angiography can also be done to evaluate for obstructive coronary disease and detect focal areas of myocardial injury in the acute setting. Cardiac MRI can also be done for structural and functional evaluation of the heart and the vasculature of the chest. The critical pathways for acute chest discomfort generally aim at the rapid identification, triage, and treatment of high-risk cardiopulmonary conditions, accurate identification of low-risk patients, and safe reduction in costs. To summarize the approach to chest discomfort, I formulated this algorithm which begins with the initial evaluation of the patient's clinical stability and presence of any life-threatening conditions. These algorithms stratify the patients to high-risk conditions and non-high-risk conditions with the following management. That would be all, and thank you.